Absolutely. So, good evening. I would like to thank the organizing committee for the kind invitation to talk about the important role cardiac CT has to play in the assessment of the tricuspid valve. And I would like to start by reminding us why we should consider cardiac CT in every structural heart disease. Echo is an exceptional tool, is the first-line tool, but sometimes it comes with limitations. For instance, in terms of acoustic windows, CT can actually overcome many of these limitations. It has high spatial resolution, providing excellent anatomical and functional analysis of the tricuspid valve apparatus, highlighting its relationship to surrounding cardiac structure, while in the setting of tricuspid interventions, it can minimize procedural complication and exposure time. Cardiac echo is one of the pillars now of the multimodality assessment of the tricuspid valve. It can study the tricuspid valve morphology, measure the right heart, SVC and IVC, and allow a more comprehensive vascular assessment and in this case, the venous assessment. By calculating the anatomic orifice area, we can have a semi-quantitative parameters of the tricuspid valve severity. To have all this information, we need at least a 64-slice CT, or ideally a more advanced dual-source CT or volume CT scanners that come with a larger Z-axis coverage and a shorter temporal resolution. We scan during the entire heart cycle, so we can have reconstructions every 5 to 10% of the RR cycle. The CT protocol involves an extended scout from the external auditory canal to lesser trochanter, paying attention not to miss the often enlarged right atrium, and finishes with an additional delayed, not-gated scan for venous access assessment. In order to have the maximal quality of the scan, and homogeneous and smooth right heart opacification is key, avoiding streak and beam hardening artifacts. We use not the standard but dedicated biphasic or much better triphasic contrast agent injection protocols that are based on a mixture of contrast and saline, and we finish with a saline flash. We can use the test bolus or bolus tracking with a technique with a region of ROI to be placed in many structures, ideally at the middle of the right ventricle, in order to avoid early or late triggers. However, in the vast majority of the cases, we need to assess the right coronary artery at the same time, so we have to shift to our standard thoracic aorta triggering to allow us for simultaneous right and left opacification. So, using multiplanar reconstruction, we can have dedicated right ventricular views in order to study the subvalvular apparatus, the papillary muscles, the chorda, the leaflets, and the commissures. We can even have cinematic images, and we can assess the regional wall motion abnormalities or the septal motion. In a similar way as we do with echo, we can even perform a volumetric analysis. And the values that we get with cardiac CT have been extremely validated and correspond to the ones that we get from the cardiac MRI. And this is important because the right ventricular ejection fraction assessed by CT or MRI is a important prognostic predictor in patients with tricuspid regurgitation. Using this volumetric method, we can have an indirect method of TR severity as per CMR by subtracting the left ventricular stroke volume from the right ventricular stroke volume, providing that we don't have any cardiac shunt or significant valve disease. And this may be helpful in patients with unfavorable echoacoustic windows when CMR is not an option. An indirect sign of TR severity is the early opacification of the IVC or hepatic veins. We can calculate anatomical surrogates for TR severity using cardiac CT. We can calculate the anatomic regurgitant orifice area during mid to peak systole or the tricuspid annular area during mid to end diastole. Using the MPR, the multiplanar reconstructions, with the plane through the tricuspid valve and through the right ventricle, we can have like a short axis view of the annulus, which is planar. We can do measurements here, area, perimeter, and dimensions. And we have to do those on both systole and diastole, as we know that the tricuspid valve is actually a dynamic structure and its area changes during the cardiac cycle. We have to bear in mind that actually the tricuspid valve is not planar, it's a 3D structure, a D-shape, saddle-shape structure. And CT can help us by giving us three-dimensional parameters. In order to do that, we use an indirect method, which is actually the same as we do with the mitral valve. We rotate the plane of the measurement along the RV plane, and we manually place seed segmentation points at the level of the anterior and posterior heads. Then we get this image, and then we apply a mathematical model, which is this red line, and this is actually the 3D perimeter of the annulus, which is then projected to the short axis, and then we can do new measurements now in both systole and diastole. And there is a high agreement between this indirect method as assessed by transesophageal and CT. We can apply the same technique to measure the gap, the tricuspid valve area. And studies have shown that this gap, as we measure from the anatomical regurgitant orifice area, as we measure for the CAR-CD, correlates very strongly with the vena conducta as assessed by 3D TEE, and moderately correlate with the right ventricular and right atrium remodeling. Oops. In recent years, especially with the evolution of the tricuspid valve intervention, cardiac CT has an additional role to play in selecting the appropriate patients for the interventions and by providing us accurate tricuspid valve size. There are different interventions that require different extra additional parameters to be measured, as well as the diameter and tortuosity of the femoral, iliac, IVC veins. And although cardiac CT is not generally recommended to edge-to-edge repair and surgical tricuspid valve repair replacement, if we still have the data before, we can measure the tethering, height, area, angle, giving predictors for recurrent TR, or even help with the catheter angulation of the edge-to-edge repair during the procedure. Another example is when we have to use the spacer device, for instance, FORMA here, where actually, we have to measure the RV size perpendicular to the tricuspid valve to the RV insertion point of the device, the height and width of the anterior papillary muscle, as well the diameters of the left subclavian vein, the left axillary vein. In terms of transcatheter replacement, except for the right ventricular and the right atrial measurements, we have to pay specific attention in the RCA on the right coronary course and the distance of the right coronary artery to the tricuspid annulus. A distance less than 2 millimeters is considered to be unfavorable and because of the possible impingement. With CT, we can provide the best fluoroscope views for procedural planning. For instance, the first one, which is RV two-chamber, can be used for the trajectory of the device through IVC in the right coronary artery. The second one, which is a three-chamber view, can help with the coaxiality of the delivery system. And the third one, which is actually a short-axis view, can assist with the coplanar deployment. Using dedicated softwares, we can actually simulate specific valves in order to have the precise size to prevent right ventricular outflow obstruction, as well as any paravalvular leak. If we are going for a heterotopic valve implantation, then CT can help by measuring the SVC diameters and areas at different levels from right atrium, the IVC diameter at the RA and IVC point, as well the height between the IVC and the first hepatic vein. Another important area is that cardiac CT can help is to understand the interaction of the leads with the tricuspid valve. However, this can be limited because of the significant blooming artifacts that from the leads, and echo might be would be better. We can use CT for the follow-up, especially when we have increased gradients through the valve. We can do 4D, functional 4D, to look for the how good the valve is opening and closing, to identify thrombus formation from leaflet motion. And we can use also 3D printing, which is an interesting area, as well as fusion imaging that may help during the procedure. In conclusion, multimodality imaging in the tricuspid valve assessment is key. CT is important tricuspid valve assessment, essential for patient selection and pre-procedural planning, while during the post-procedure course, it can investigate the causes of valve dysfunction. Thank you.
Thank you very much. Very comprehensive talk. I think that we have discussed all the strengths of cardiovascular imaging modalities in evaluation of tricuspid valve, morphological data for tricuspid valve and right ventricle, and all the other anatomical data. So, do you have any questions or?
Thank you very much for the presentation. The CT is ACG gated, right?
Yes.
So if the patient has atrial fibrillation?
Yes, with the advanced technology, with the newest card, it's not any issue.
Okay.
The most important thing is to have as high temporal resolution as possible. So beta blockers may be the key to that, to have as close as 60 beats per minute. But with the advanced, the dual source, or the volume scanner, this should not be an issue.
Okay, thank you.
Okay. So, a question? Okay. Dr. Nikas?
Hello, it's Dimitris Nikas from Ioannina, Greece. Just a short practical question. sometimes we find difficulty to see if tricuspid regurgitation caused by pacemaker or bladder defibrillator lead, it's the cause, or if it's caused the adhesion or puncture of the tricuspid leaflet. Do you think that this is the CT could help us more than the cardiography to find out what's the main reason? Because this is something, I don't know, I would like to have the opinion of the panel. This is really difficult for us sometimes to differentiate which is the main cause.
Yes, it can help. Sometimes, though, you can see actually with cardiac CT, with functional imaging, how the lead interacts with the commissure or the leaflet, and see if it is stuck there or not. But sometimes we may have blooming artifacts because of that lead, and then maybe echo is a much better choice. So generally yes, but it has its own limitations. You cannot predict actually from the beginning.
Okay. I would like to thank all the speakers, the moderators, and all of you. And we continue to the next